Good morning, everyone. This is Lisa Myers with ARX Healthcare in Franklin, Tennessee. On behalf of the Tennessee HFMA chapter, I want to thank all of you for joining us today. We're unable to get the slides posted on our website. If you would like to have the slides after the presentation, you are more than welcome to reach out to the Tennessee HFMA chapter and we can get those sent to you. I have a few announcements before we get started. Want to make sure that you are saving the date for our upcoming Fall Institute, which is scheduled for October 18th through the 20th, and this will be held again in beautiful Gatlinburg, Tennessee. We're going to have a great lineup of speakers and topics that you will not want to miss, and more details will be available soon on our website. Additionally, our next webinar will be on July 11th, so if you'll also be on the lookout for details for that to follow. Requirements to obtain CPE certificates today. You must be connected to the webinar for at least 90% of the duration. You must respond to at least 2/3 of the polling questions. Today we are fortunate to have Mr. Bruce Tichenor. He has been working within revenue cycle management since 1980, specializing in customized patient balance environments for both hospitals and large physician organizations. For the last 20 years, Bruce has spent the majority of his time working specifically with clients developing patient contact center services that are effective at increasing patient satisfaction, account resolution, and higher percentage recovery of patient-responsible cash dollars. He is passionate about changes in healthcare reform and how this is impacting healthcare organizations and their patients with reduced reimbursement as well as higher patient premiums, copays, and deductibles. Bruce now travels from East Coast to West Coast working with healthcare organizations to uncover opportunities for improvement while maintaining patient satisfaction and loyalty. Bruce will also have a colleague of his on the line with him today helping out, Justine Matthews. And at this point, Bruce, I will turn it over to you and you can tell us a little bit more about Justine and get started when you're ready.
Hi, everybody. I hope you're having a great day today. And I just do want to take a minute to have Justine introduce herself and tell you a little bit about herself, and then we can get right into the program. Are you on mute, Justine?
Good morning. This is Justine Matthews. Happy to be assisting Bruce today. I am about 25 years in the industry, working on both the provider side and the partner side, focusing in AR management. I'll be speaking to certain trends we're seeing in the market today.
Thank you. I want to talk a little bit about what we're going to reach out to and cover today regarding the changes related to the Affordable Care Act and how that's impacting patients with regard to reduced insurance reimbursements, which hurt the patients as well as our hospitals, the higher premiums and copay deductibles that everyone is running into across the country, and the rapid growth in patient-responsible balances. Actually, it's becoming one of the larger financial classes to pay attention to with regard to your overall AR and a lot of demographics of the United States. We also want to talk about managing patient loyalty and what we can provide from the standpoint of outreach and workflows for your, with your patients, ideas that you can incorporate into your processes that you may or may not already be doing, and developing patient-friendly initiatives, especially with patients having higher balances. They're becoming a little bit more easily agitated, if you will, or frustrated because patients still don't totally always understand their insurance benefits if they have them, and what the coverages are going to be, and how to better communicate with the patients. In today's session, we're going to discuss the impact of the growing patient balances in the United States, trends related to the patient balances as a percentage of providers' gross AR, identifying baseline recoveries along the way, how are you really doing with regard to recovering your patient balances against your overall patient balance inventory roles, and how to be effective at that. Effective workflows, utilizing new technology tools, and discussing those opportunities. Guiding principles for protecting your patient satisfaction and loyalty, which is at the top of the list of all of the different organizations that Justine and I work with on a daily basis and call on. Leveraging any additional financial tools to provide payment alternatives to your patients. The impact of healthcare from the Affordable Care Act has been dramatic, especially in the last 5 to 7 years. The growth is really just escalating. And what I thought I'd do is have Justine talk with regard to healthcare spending and this overview here.
So as it relates to the healthcare spending, this slide was a clear indication of where our focus needs to be. The GDP is stating that we should see 4 to 5% increase annually, which is scary given our current state in the economy and the current state of healthcare. The next couple of slides are going to walk us through how we can interpret this data and what actions we can take to help set ourselves up for success in terms of patient liability.
Thank you, Justine. And basically, one of the things that helped to really, take that percentage growth and put it into a dollar amount. Kaiser Family is one of the organizations we like to follow with regard to patient balance growth trends. And between now and 2023, there's an expectation to be about a $200 billion increase in patient balances across the United States for our entire healthcare providership. That's a tremendous amount of dollars that you're going to, as a hospital organization, have to carry that in your AR because it doesn't necessarily mean that those patients are bad debtors, but they may need longer periods of time to pay their balances off. So this is just an example of what to look for, or you may already be seeing the impact on your financial AR now. And so we go to the next, the first pop question, Lisa, that you would have.
All right, so polling question 1. What percentage of growth in patient balances has your health system experienced over the past couple of years? 5%, 10%, 15%, 20%, or greater than 20%? Just a reminder, in order to obtain CPE certificates, you must respond to at least 2/3 of the polling questions, and we will have 4 today. I'll give everyone just a few more seconds to finish voting on that. All right, and this time I'm going to close the polling question and share those results. It looks as though 13% say 5%, 30% say 10, 26% say 15, 17% say 20, and 13% responded greater than 20%.
So, as you can see just by the poll, there's been a tremendous shift in what's happening with your patient balance financial class, whether it's true self-pay or balance after insurance. We're seeing significant increases in patient balance AR. And so the problem with that, and this is interesting, I was down in Florida doing a presentation at the Florida AHAM program in Jacksonville. And Richard DeSoto actually was at that particular presentation, and we were talking about the uncollected dollars that are continuing to roll in your inventory. And he came up to me after it. He was laughing because he said, you know, it's interesting. I'm glad people do, you know, read my research and my articles. And I said, yeah, but this is 2015. And he said, I'll be coming out with new data here in the not too distant future. So I would assume you'll want to look for that in HFMA. But with regard to, you know, if you're looking at the organizational type, and you look, if you're a physician group, you know, basically, I was at a meeting in Denver not too long ago with a very large physician organization that fell into the organizational type statistics here. And in talking to the Vice President of Revenue Cycle, we were looking at this grouping, and he started to laugh, and he said, you know, that you're not going to believe this, but we are at 24% of our overall AR in dollars in patient balances now. And so the challenge that he had, though, is he's got 496,000 accounts that he has no ability to service, and that in that rolling inventory that they're sending statements out on. And statement processes are not inexpensive at all, as we all, I'm sure, know that. But so there was definitely an interest level in what can they do to improve their internal processes so that they can reduce their statement processes, maybe electronically, what have you, whatever they could do. But if you can take a look at this, you might see yourself, your own facility may fall into some of these percentage of AR dollars categories, depending on whether you're, you know, a multi-hospital system, you know, whether you're large urban, or if you're, you know, a community hospital, or even a remote type facility. But this is just an idea to look at the growth that's been going on. And by the way, when I was talking with the physician organization, VPRC, they had been running about 10% of their gross AR from a patient balance standpoint. So this is just one of the self-pay AR slides I wanted to show you today. And then, Justine, I was going to have you talk about cumulative increases in health insurance premiums, and talk to that, if you will.
Sure. So this slide is meant to really just use as a visual to show us certainly what most of us know, right, that we've had since 1999 to 2016. There's been an increase in worker earnings, but the health insurance premium compared to the increase in worker earnings is far more than what the worker earning increase has been. So if you see the worker earning, the blue line at 60%, the health insurance premiums have an increase of 213%. And the worker contribution has an increase of 242%. So with that being said, when you analyze the existing self-pay population, there's less, the worker themselves has less in their net check to pay for those out-of-pocket expenses, hospital-related, physician-related, etc. You know, so I think this is an important slide to really show what the significant gap is between earnings and health care cost.
And what's interesting about that is that the high premiums are taking those dollars that normally would have been paid to you, that now are being paid to your payers, but then they're still not the coverage capability that, you know, existed, you know, 10 years ago, and here they're paying a lot more money today. So I agree with Justine. This is an interesting slide to look at and to evaluate your own AR needs and understanding that better. That leads us to the next top question, Lisa, if you will, and then we can move forward.
All right, so polling question 2. What percentage of your gross AR is patient responsibility? 5%, 10%, 15%, 20%, or greater than 20%? And again, just a reminder for those of you who want to obtain a CBE certificate for today, you must respond to at least 2/3 of the polling questions. It looks like we have almost everyone voted. So I will go ahead and close that polling question now and share the results. About 13% say 5, 17% say 10, 35% say 15, 26% say 20, and 9% responded with greater than 20%.
So that's a great indicator as well for what we're going to get into in preparing for how to handle those percentage increases. One of the things that Justine and I work with all the time is helping hospitals identify their baseline performance internally. And it always is interesting to me that even though we look at age trial balances and things like that, and we'll see your 0 to 30 buckets, 60 to 90 day buckets, etc. When I actually get in and start talking with facilities and consulting with them, we find out that they really don't know, each month the cash that they're receiving from their statement processes, point of service, versus what their rolling inventory is. What is actually their baseline performance? Is it 5%? Is it 20%? Is it 30%? What's your true self-pay recovery versus your balance after insurance recoveries, et cetera? So we've created a little bit of a patient pay yield document here, if you will. And again, you can get this deck from Lisa. She can send it out to you, and we'll make sure that this can be sent out to everybody if you need it or want it. But to understand how you can improve patient pay collections, you first need to know how well or poorly you're doing. So we like to take the patient payments collected within 5 months from a date of service. Actually, I use 12 months because that really gives a true, if you're looking at what your true performance is, I like to go back 12 months. But then you take all the patient charges resulting from visits in a given month. So, and that will give you your patient pay yield. So it's basically, that's one way of looking at that. There's a multitude of different ways to look at it, but this was one that we wanted to give you. And then another way that we look at it is, what does the improvement do if you look at, I don't know if I can go back here or not, I'll try previous slide. Another way I like to look at this right here is you take your patient cash recoveries for that 5-month period, and you take your revolving AR or your total inventory AR for patient balance that you're sending statements on. So each month when you look at this, you might have a revolving $50 million in your ATB total, but you may be recovering $3 million in monthly cash, and that's excluding point of service. So that gives you a baseline there too, and what can you do to improve on that baseline? And I'll show you some, later on in the presentation, I'll show you some ways to look at that. But what happens when you can grow your internal performance by a cash improvement of 1%, 3%, or 5%? And it can be, you know, a significant dollar amount, and it has a direct influence on your bad debt, you know, and what you're going to send to your collection agencies. Because if you can recover an additional improvement of 1 to 5%, and I'm not talking about, you know, charity or anything like that at all. I'm just talking about cash that you normally would have sent over to your collection agency. If you can recover that, you're going to lower your collection agency expenses as well. So in this scenario, when you get into a multi-hospital system, you're talking about $12 million if you're at 5% improvement. So there's a reason to really pay attention to opportunities to improve your self-pay recoveries, whether it's, you know, a physician group or it's a multi-hospital system or urban. But even in groups with physicians, 800 to 1,000 physicians, I'm seeing, you know, that 5% is actually because the average patient balance, depending on your specialty practices and everything, are growing, and it could be even greater than that 610,000. This is what I call a return on investment, but establishing baselines. And one of the things in this particular model here, this is actually a multi-hospital system we were working with that had a rolling inventory of $518 million. And then their baseline recoveries for the year was they were running at 11% in their total recovery. So they were recovering $57 million. And their cost to administer that was 6.50%. So basically, what they were looking at was a total cost of $3.7 million. And so their net back was $53 million. So what we did is we went in and we looked at their performance and what was their opportunity for improvement. First of all, we needed to understand what their break-even was, you know, based on whatever their fee structure was going to be. So if we could take that 6.50 and lower it to 6%, but improve their 11% recovery by 3 percentage points, and this is different from a cash recovery. This is just a pure liquidation recovery. But if we could take them from 11% to 14 or 15 or 20%, you can see basically the improvement in their net cash back. And so these were, you know, examples that we were working with, and typically we end up somewhere in the middle performance. Now this particular baseline ROI included taking over all of their expenses, for example, associated with statement processes, lockbox processes, everything. But what was important about it is that just by changing a few things and tweaking a few things, they could definitely see a fairly significant increase in their recoveries. When you look down at their cash improvement recovery, if I can find my mouse, in the green, you know, $15 million to a potential for $46 million. And that all went to their bottom line with regard to reducing their bad debt collections. And that helped to significantly reduce their costs associated with that, and gave a lift to their patient satisfaction as well with this model. So, Lisa, if we can move to the next pop question, we can talk a little bit about the next steps.
Sure thing. So polling question number 3. Do you know what percentages of your monthly patient payments are collected against your patient balance open AR? Less than 10%, less than 20, less than 30, less than 40, or less than 50%? This is polling question 3 of 4, so just a reminder one more time for those of you who would like to obtain a CPE certificate. You want to make sure you respond to at least 2/3 of the polling questions. We've had about 92% voting, so give everyone just another moment or two to get that response in if they would like. All right, I'm going to go ahead and close that polling question, share the results. 30% say less than 10, 39% say less than 20, 22% responded with less than 30, 9% responded with less than 40, and 0 respondents responded with less than 50%.
And that's interesting. Let me, for example, for physician organizations, we see their overall recoveries anywhere above 50%. I've seen them as high as 80%. And the reason for that is because of the doctor-patient relationship. Typically, you know, patients want to take care of their physicians and get them paid. On the hospital side, to give you an example, for if I break out your true self-pay, typically we see somewhere between 4 and 5%. And then on balances after insurance, we can see it as high as 55%, but it should be somewhere around 42% or greater. Combined, we like to see for our hospitals, you know, at least minimally in the 30 to 45 percentile combined. If you're looking at your AR total cash recoveries against total AR roll, we'd like to see somewhere between 35 and 45%, and that's doing pretty good. If you're lower than that, it could be due to, you know, your payer mix, things like that. But there are opportunities to improve upon that as well, and get more cash in the door. So one of the things we want to talk about is effective strategies with regard to, you know, staffing, technology, and protocols to increase collections and reduce your write-offs, but maintaining patient satisfaction. And one of the things that we recommend strongly to everybody, whether you're doing an internal or an external process, it's critically important to really get your staff trained. For example, point of service has been a growing trend for a long time. But one of the things that we see time and time again is that you know, the registration or access staff, the financial counselors, there's a need for a lot of training there and getting them comfortable with asking the patient to pay their co-pays, things like that. But that's something, a point of service area that I would strongly encourage everyone to continue to really be diligent about training those folks to be comfortable to ask their patients, you know, for the co-pays. None of us can go to Walmart and buy groceries and walk out and we send a check later. So it's just one of those things that take a look at your ER and what can you do to help, you know, collect those co-pays there at the ER before the patient leaves. And there's a lot of great models out there that I've seen. I've seen some where the nursing staff or whatever will will give a patient a big 8.5 by 12 red card that says, see this person on your way out, things like that. So it takes that type of pressure or financial responsibility off the folks that are actually, giving the patient treatment, because they need to concentrate on the patient for what their needs are and take care of that. Others I've seen where they've put a financial counselor at the exit door at the ER, and actually the patient can't get out until they've at least talked with the financial counselor at the door, and there's a credit card machine and the ability to take payment right there. So I would encourage strongly a high level of training, constantly training, your patient advocates, your people that are working on the phones, to be as patient-centric as they can, but help the patient, guide the patient to make their payment. Dedicated teams are an important aspect of any partnership. If you're using an outside partner, they should have a dedicated team that's working for you. Internally, you should have a dedicated staff that can, take those inbound calls, and especially have enough people so they can answer the phones, because those inbound calls are so important, because those are patients with questions that will ultimately pay their bill. And if you're not making outbound calls, maybe you can make it so you can call your higher balances or do something like that. But reach out to the patient population to try to get them to facilitate sending in a payment or getting them on a payment plan. As far as found insurance and follow-up, those are important things too. We do see, it's interesting, about 15% of a lot of patient balances that come through our organization, 15 to 20%, will find secondary insurance. So again, back to the training perspective with regard to your onboarding staff, making sure they're getting all of the insurance, because there's nothing worse than the collection agency actually finding more insurance, at the end of the process as opposed to the front end of the process. As far as if you're utilizing any type of a partner, and you may have the tools yourself from a sophistication perspective and technology to be able to record calls for training and quality perseverance, because that's something too. It's interesting, you may have some patient escalations that come in, and if you're recording those calls, you'll find out that probably a lot of the patients were just frustrated and venting. But that can be very hard on your staff. It can be very demoralizing. So we always encourage, follow-up training, and if those people have been really abused in a call, give them the opportunity to take a breather and walk away from the phones for a little bit, because it is a very tedious job. The ability to companionate your accounts, and one of the things that we're an advocate for is Guarantor Billing. My father-in-law was a good example. At one time when he and his wife were alive, they would get 20 or 30 statements of all different kinds, and I would sit down and help them understand what this was for, what that was for, and a lot of it was just insurance was pending, but they were getting encounter statements, and they were in their 80s. They were pretty frustrated with the process. So anything that we can make it easy for patients to pay their bill, such as rolling, they're sending out maybe an encounter statement or summary statement, and then roll everything up into a guarantor bill, so there's an opportunity for them to understand what the bill is really about. But the one thing I do know about statement processes, if the statement is confusing to your patient, and you're sending that out, and they don't understand it, they may step back and wait until the next statement comes and then pay it, or they may call in, but chances are likely a lot of patients that don't understand their statement won't pay until they really feel they understand the statement. So that could be slowing down your reimbursement from your patient population. So those things are very important from a companionation perspective. Also, when your patients call in, be able to answer the phone and provide a resolution when they're on the phone with you, so that they don't have to keep calling back, because that just inundates your internal phone lines to the point where patients end up going to voicemail. Settlement. I don't know if you all do settlements or not, but tax season's a great time to look at doing settlements, both in the fourth quarter and in the during the January through April. But even on an aging account, if a patient owes you $1,000 and they say, I'll pay you $900 if you'll give me a 10% discount, I would suggest looking at what can you put into your policies and procedures regarding settlements. And then for any outside vendor partnerships, having a sophisticated IVR is important. I've worked with hospitals that have their own dialing systems that patients can call into and self-serve. So if you're looking at technology today, find something that will help that patient that really doesn't want to talk to anybody, just wants to pay their bill. And that can also be done through your payment portal and your websites. And make multiple payment options available to your patients today. Average balance is, I was on a flight with a gentleman that was an attorney in Chicago. His monthly premium for his family was $1,700. So he was over $17,000 a year in premiums. His copay or his deductible was $10,000. So that gentleman was going to be out somewhere between $27,000 and $30,000 before he would ever get any kind of insurance. So you have a lot of those patients, I'm sure, that are floating around with your open patient AR. Other things that we've kind of already talked about a little bit, but statement solutions, having color statements. I know they cost more, but you can do a lot with patient-friendly color statements. You can guide the patient to the areas that you really want them to focus on and read, with color arrows or what have you. And being able for a patient to read their statement is critically important. Enlarge your phone numbers, your inbound phone numbers, where you want them to call if they have questions. And again, being able to answer the phone is critically important. And having people that are well trained to be able to, answer that patient's questions right there on the spot, so that you have one call resolution. Payment processing, offering patients opportunities on how to pay their bills, either through electronic means, whether it's through your payment portal, and they can go out onto your payment portal and hopefully be able to see their statement. Hopefully your payment portal's got enough robustness that it allows them to set up payment arrangements right there that would follow your payment policies and procedures and guidelines. Those kinds of things are critically important, because we all work, and most times when our hospital business offices are open, they're from usually 8 o'clock to 4:30 or 5, Monday through Friday. So patients may, after hours, have questions or have a desire to make a payment, whether it's in the evening or on the weekends. So providing them that payment processing tool to get that done is really, really important. Operational intelligence. It's really important, I think, for everybody within the operation from the front end to the back end to all understand each other's role and how to work with patients and to diffuse patient frustrations and concerns. And I think timeliness, getting back to patients quickly, is very important, because one thing none of us like to have is a board member in our office because somewhere along the line the patient slipped through the cracks and didn't get their questions resolved. And it may be it may be their fault. They may be going into the payment portal and trying to make a payment, and they're just not doing something correctly, and then they file a complaint. So so whoever that patient's going to talk to, we would want everybody in the operation to understand how that payment portal works, or your payment plans and how those are set up, all of those things that are available to the patient. Having dedicated patient advocates, I think, are important for all of our hospitals. Having a team that really, if you want to call them patient customer service team or patient advocate, or financial counselor, or if you have an outside partner, making sure that they're dedicated and they understand your policies, your procedures and protocols, and what your statements look like. Do they have access to look at the statements? What the workflows are. If you have, payment discounts, what those are. Understanding your 501R. All of those things are critically important with having a dedicated team, whether it's internal or external. Your outbound call solution. I work with a lot of people on a daily basis, Justine and I do, that make absolutely no outbound calls internally out to their patients. And I would, somehow, if you can get the time and the people and the personnel to do it, I think that's a critical piece of communications with your patients, and that will end up giving you financial rewards. Again, back to having some type of self-service solution, I believe that that's critically important for our hospitals today and their partners, whoever they're doing business with. Additionally, in looking at how to stratify your accounts, there's a number of technologies out there. There's propensity to pay technologies. There's, also with regard to patients that may meet your charity guidelines, that type of thing, technologies that are available to all of our hospitals. And we encourage you to utilize those to help segment your account inventories. Like I said earlier, with regard to accounts you may want to prioritize to make outbound calls to from your own team, for example, higher balances that are going to take time to pay back. You may have financial programs, loan programs available that you can, suggest to those patients. Obviously, you can't tell them they have to do this because that's a banking issue, and we can't make any patient fill out a financial application to take out a loan. But developing that best call list or a work list for outbound calls internally can help to also increase your patient loyalty and satisfaction. The charity, presumptive charity technology is a great technology today. We encourage everybody to run that. It will help you reduce your statement cost. It will help you move accounts to presumptive charity and save time. Because what we found out, even though that's going to reduce the number of statements you send out, you'll be more effective with those patients that you're working with that can pay their balances, because you're focusing on those patients that will pay their balances versus having to work with patients that you're going to need to send out a charity application to. If you can utilize technology to do that, that will save you a lot of time and money. And as far as address updates, I can't stress that enough. Again, it's really important and very difficult sometimes to get the correct address. But if you can get those and you're doing your own statement processes, most statement vendors will provide you with NCOA, something like that, but you may want to even take it further and look at, stratify your balance after insurance accounts and balances over $1,000 that you don't have a good address for. You may want to incorporate a skip trace company that will charge you, $2 or $3 to find that person. And when you have a 40 to 50% chance of that patient paying their balance, it's worth that $2 or $3 to look at those larger balances to see what you can do to find those folks. Anything that you can do with regard to effective strategies and creating, questionnaires for you and your access people or front-end people to get. I will tell you, for example, Social Security numbers are critically important, especially today if you're going to move accounts to a bad debt agency. They have to have the Social Security number to be able to really legitimately work those accounts. They have to go through and make sure those accounts aren't in a bankruptcy status, deceased status, what have you. Without the Social Security number, collection agencies legitimately cannot really do a whole lot with that account because they don't know if they've really got, they can't really validate, do they have the right person. So if you're not, capturing Social Security numbers, I'd encourage that to be a part of your process. And then understanding at the end of the day, your workflow methodology can increase your cash flow if you can remove some of these work practices that we're looking at here. So when you rank your accounts in order, you know what action to take. And this is good information not only for yourself internally with your revenue cycle management, but if you're utilizing an outside partner, I would sit them down and say, let's talk about this. What are the workflow processes? And what can we do to increase and enhance our ability to recover more cash dollars, especially when you look back at the increase in your patient balance AR, as you've all looked at today on the pop questions. Some of those dollars are very significant, and there are ways to try to even reduce that by 2 or 3%, and that can be significant in dollars recovered. One of the things that we work with a lot of clients on is their workflow opportunities and their statement processes. Some like to send 3 statements. Some like to send, 5 statements. Some like to send, a summary statement, an encounter statement, what have you. One of the things that we encourage all of the organizations we work with to do is, I call it the 3+2. That doesn't mean that this would be right for your organization, but it's where the patient receives an encounter statement and 2 summary statements or guarantor statements and 2 pre-collection notices. One is a past due notice and one is a final notice. And there is a change up between the statement look and the letter look. And it's interesting because the letter look, which is, I like to call it the 4th quarter of the Michigan-Ohio State Buckeye game, at least back when Bo Schembachler and Woody Hayes were coaching, because they were always close games. They haven't been lately for my Michigan Wolverines, but the fact of the matter is that when you're down to that last bit of 1-yard line where you can actually try to get those dollars in before you're going to send them to bad debt, normally somewhere probably between 120 and 150 days. You want to get something out there that's a change-up, an audible call, if you will, so the patient sees there is a difference. Maybe you've been making those outbound calls, you've sent those statements, and you're still not hearing from that patient. But when you send that patient to bad debt, that patient still may not be totally recovered and back to work yet. So all I'm suggesting is take a look at what can you send to that patient that's different. Maybe it's even changing the color of the last notice or whatever, but something final so the patient gets that, they open it, and it may entice them to call in. And approximately 11% of the time, when you're at that point where you're ready to send that account off to your collection agency, you can get about an 11%, 10% response from sending a pre-collection notice to that patient. And it's something that you can draft up. It has to be first party. The days of utilizing a third-party collection agency to send out a pre-collection letter under their logo has been gone for probably 15 years. But you can still send that out and still have the same effect with that patient, letting them know that this is past due. And you may want to change up making your outbound call at that point. But give that patient somewhere, if you're going to do 2 notices, give them 10 days to respond, and then send the second notice and give them another 10 days to respond. And then you've done everything you can. If you're making outbound calls, you're sending statements, and you're still not hearing from the patient, you're looking at all of the propensity to pay technology and charity technology and everything, then you can sit back and say you've done everything you can to try to get that patient to communicate with you, and it's time to send them to bad debt. But this is just a workflow, if you will, on how you can look at it, how to manage payment arrangements, that type of thing. And I'm not saying that this is for you, but there should be a high level of call attempts or contact attempts utilizing both statement processes and the phones to try to connect with people. So Lisa, that moves us to the next pop question, number 4 in the presentation, and I'll let you take it away.
Absolutely. So this is our 4th and final polling question. Which of the best practice strategies below should be considered to optimize the liquidation of patient balances? Workflow strategies, patient-friendly statements, patient payment portal, presumptive charity, propensity to pay technology, or all of the above? And again, just a reminder for those of you who are hoping for CPE certificates, you must respond to at least 2/3 of the polling questions, and this is our final one. Give everyone just a moment to vote on that question before I close the poll. All right, I'm going to go ahead and close that and share the results. So Bruce, it looks like 14% say workflow strategies, 10% say patient-friendly statements, 5% responded with patient payment portal, 0% responded with presumptive charity, propensity to pay technology, and 81% responded with all of the above.
Great. And I know I'm running short on time too, Lisa, so I didn't realize I could talk so long. But I'll go through the guiding principles for protecting patient loyalties very quickly. And one of the things that, and this kind of says it all, with regard to patient advocacy, again, back to training, compliance knowledge is critically important, and technology proficiency. And a lot of the facilities we work with really go through a lot of training on technology proficiency. So telephony capabilities, not everybody's got those capabilities, but if you can look at your budgets and put it in, it's something I'm telling you that's worth it. And then looking at your a sophisticated workflow process. It's really important to have patient-friendly statements. HFMA came out with that a long time ago. Critically important to have easy-to-read statements. A web payment portal solution that your patients can work through. Lockbox, electronic lockbox is important to get those payments in and electronically upload them into your system so that if you're behind on posting cash, this is really patient-friendly to get those dollars in. Payment plan management with regard to payment arrangements, financial application capabilities, things like that, and having some type of a call drop forward solution if you can. And then as far as, again, protecting patient loyalty, looking at your correspondence backlog, how you're getting back to patients in 1 day or less. Average hold time should be less than 50 seconds, for any time anybody's holding on the call. You should have less than 2% call abandonment. Percentage of calls resolved in 6 minutes should be 85%, and your percentage of calls not resolved in 10 minutes should be 5% or less. So with regard to your overall inventory, you should be providing a resolution of 99%. And then optimal outcomes, again, a lot of this goes back to enhanced quality, supervisors, managers, your best call library, Q&A management team, and training. Training. And so these are some of the things that we would recommend that you look at if you're looking to retool in any of your patient balance revenue cycle needs. And that takes me to the end of the program.
Great. Bruce and Justine, thank you both so much. At this time, if anyone has questions, you can enter those in the chat box, and I can relay those to Bruce, read them out loud so that the entire audience can hear. Bruce, in the meantime, while we're waiting to see if there is any questions that come through, if you would like to share your contact information, maybe just, spout that off a couple times, give people a chance to write it down if you'd like.
Yeah, actually, my name's Bruce Tichenor, and that's spelled T as in Thomas, I-C-H-E-N-O-R, and my email address is btichenor, and that's, again, B as in boy, T as in Tom, I-C-H, E as in Edward, N-O-R, at convergentusa.com. And that's Convergent just like it sounds. And my phone number is 419-348-9864. And feel free anytime to call me. And Justine, do you want to give your contact information, please?
Justine Matthews, M-A-T-H-E-W-S, area code 863-804-0570, and it's J Matthews, M-A-T-H-E-W-S, at convergentusa.com.
Great, thank you both. And we are going to work on getting the slides uploaded to our website, which is tnhfma.org. You'll go back to the same place where you registered for today's webinar, and we'll have a slide deck link there where you'll be able to download those slides later on. I apologize for not having those ready today, but we will get those uploaded to the site so that you can log on and download them at a later point. So I don't see any questions that have come through right now, hopefully with you all sharing your contact information. If anyone would like to, they can reach out to you individually. Thank you both so much for being on today. Certainly enjoyed having you speak to us. And at this point in time, unless there's anything further, we will end our webinar.
Thank you, Lisa.
Thank you, Bruce. Thank you, Justine.
Thank you.